Zoll LifeVest is a proud sponsor of CardioNerds. Zoll has continuously improved LifeVest for over 20 years, leading to a median real-world wear time of 23.4 hours per day and an AI-enhanced algorithm that delivers zero median false alarms at 90 days. The newest LifeVest garment is lightweight, breathable, and preferred by patients for its comfort. Learn more at lifevestinnovation.com.
Hey Cardio Nerds, welcome back. We are here today with another fabulous CNCR episode. This is Eunice Dugan. I am a interventional and structural fellow at the Cleveland Clinic. I'm here with the wonderful Dr. Dan Ambinder. Hey Dan.
Hey Eunice, it is so good to be here. I'm pumped to learn about an amazing case from the colleagues that we have on.
That's right. We have some wonderful people on with us. We have Namrita Ashokprabhu, Dr. Yulith Roca Alvarez, and Dr. Mehmet Yildiz from Christ Hospital. Hey guys, how's it going?
Good. It's awesome to be here. I'm Namrita Ashokprabhu, and I work as a clinical research coordinator at the Women's Heart Center at the Christ Hospital. I completed my undergraduate education at the University of Colorado Boulder, SCO Buffs, and I will be beginning my medical school education this upcoming summer.
I am Yulith Roca. I am a clinical and research fellow at the Women's Heart Center in Cedars-Sinai Medical Center, and I did medical residency in Catherine Health in Ohio, where I work with the Christ Hospital, and I will be starting general cardiology fellowship at Loma Linda University on July.
Hello, CardioNerds. I'm Mehmet Yildiz. I'm a second-year cardiology fellow at the Christ Hospital. Before my fellowship training, I was a research associate at the Linear Research Center at the Christ Hospital.
That's awesome. Thanks for joining us, guys. So why don't you set the scene for us in Queen City?
So Cincinnati has a lot to offer. I've only been here for about 2 years, but if I had to pick a favorite spot, it's tough to choose between over the Rhine, the banks, and the Central Business District. The food scene here is a standout, and no, I'm not talking about Skyline Chili, though I may have lost some followers here. Over the Rhine has gems like the Eagle for comfort food and some of the best craft beer at Rheingeist. And you can't leave Cincinnati without indulging in a scoop or 3 of Graeter's ice cream.
That's so great. I haven't been to Cincinnati in a long time, but these things make me want to go back. I got to check it out pretty soon. Thank you guys again for joining us. Now let's get into our case. Namrita, what do you have for us today?
Yeah, so today we're diving into a challenging case of recurrent chest pain that exemplifies the diagnostic complexities in patients with refractory anginal symptoms. So we've got ourselves a 58-year-old white male with a history of previous smoking, hypertension, hyperlipidemia, type 2 diabetes, and a strong family history of cardiovascular disease, who presents with a long-standing history of intermittent at-rest chest pain episodes. Our patient recalls experiencing chest pain starting at about the age of 44. In 2009, he had an exercise nuclear stress test that showed 1 millimeter of downsloping ST depression in the inferolateral leads, but normal myocardial perfusion imaging. He was later referred for coronary angiography, which revealed normal coronaries. His stress test findings were later dismissed as false positive. But despite all this, he continued to have at-rest chest pain episodes for over the next decade. In 2017, he returned to the ER with a worsening pattern of chest pain, both more frequent and intense episodes. He described these as sudden, crushing chest pain located substernal and non-radiating, accompanied by diaphoresis, lightheadedness, and shortness of breath. His workup included an EKG, which at the time revealed new T-wave inversions in the inferior leads 3 and AVF and negative troponins. An echocardiogram showed preserved ejection fraction and no wall motion abnormalities. But given his strong family history of coronary artery disease, he underwent another left heart cath. While there was no significant epicardial coronary disease that was found, there was diminished TIMI2 flow in the LAD, raising concern for coronary microvascular dysfunction. He was started on aspirin 81 milligrams daily, atorvastatin 81 milligrams daily, isosorbide mononitrate 30 milligrams daily, and amlodipine 5 milligrams daily. Later in 2022, 5 years later, he returned to the ER once again with a similar pattern of chest pain at rest. His EKG showed no ischemic changes, but his high-sensitivity troponin peaked at 325. He was later admitted for a non-STEMI and underwent another left heart cath, which revealed mild non-obstructive coronary artery disease with about 40% stenosis in both the proximal and distal LAD, as well as mild irregularities in the posterior descending artery. Sluggish flow was also noted in the LAD, similar to his previous angiogram. He was informed that coronary microvascular dysfunction may have contributed to his symptoms, but no further treatment was initiated and he was discharged. Despite no significant epicardial disease, he continued to experience intermittent chest pain at rest. A few months later, he presented to the Christ Hospital ER with another severe chest pain episodes. His EKG showed non-specific, diffuse borderline T-wave changes, but no SD changes and high sensitivity troponin peaking at 1,396. He was admitted for a second non-STEMI and underwent left heart cath the following day to rule out any sort of plaque rupture or thrombosis. Once again, angiogram revealed non-obstructive coronary arteries. At this point, our patient has experienced over a decade of random at-rest chest pain with multiple ER visits, hospital admissions, 2 non-STEMI events, and 4 invasive coronary angiograms. Despite all of this, no culprit vessel has been identified, only mild non-obstructive CAD and diminished flow in the LAD. Yet he still lacks a definitive diagnosis or any sort of targeted treatment.
Wow, thank you for laying that out. I really feel for these patients. I mean, this definitely has to be affecting his quality of life. He's been dealing with this for such a long time. Mehmet, based on the patient's history, what would be your next step in the workup of this patient?
Yeah, at this point, he was admitted with a second MINOCA event. MINOCA has a broad differential diagnosis from coronary vasospasm to coronary artery plaque rupture or embolism or SCOT. There's also another group of condition which is called MINOCA mimickers, which includes myocarditis, non-ischemic cardiomyopathy, and Takotsubo cardiomyopathy. Currently, cardiac MRI is a first-line imaging tool to assess these MINOCA patients. Cardiac MRI should be a routine part of our care protocol for MINOCA patients, and more importantly, it should be done within a week of MI as recommended by European guidelines. Also, it is critical that MINOCA patients should be treated with statin and ACE or ARBs, as this has been shown to decrease MACE.
So, as Mehmet pointed out, our team decided to proceed with a cardiac MRI, and this was done within a week. And the MRI results showed a mid-wall late gadolinium enhancement, or LGE, in the mid-anteroseptal and mid-inferior segments of the myocardium, along with focal increase in the extracellular volume fraction, or ECV, and native T1 mapping. Additionally, there was evidence of active inflammation and edema shown by increased T2 mapping. All these findings from the cardiac MRI pointed to a diagnosis of myocarditis.
Geez, myocarditis, that's a pretty significant diagnosis. I guess when that comes up, I always think about any viral infection. So did the patient have any recent viral illness or infections that could point towards myocarditis as an underlying cause?
That's an excellent question, and you're absolutely right to consider a preceding viral illness as a potential trigger for myocarditis. Interestingly, the patient didn't report any recent or past viral infections. No fever, no other symptoms suggesting a viral source. And also the type, history, and current nature of his chest pain don't quite match the usual myocarditis cases that we see after a viral infection or with inflammatory conditions.
You're right. That's pretty fascinating. Without a clear viral or infectious trigger, and considering the nature of his chest pain episodes for a long time, myocarditis seems less likely. Instead, would you say this presentation aligns more closely with potential diagnosis of coronary microvascular dysfunction or vasomotor disorders?
Absolutely. In this particular case, who had INOCA years ago, then having chest pain, mainly nitrates for many years, and now having MINOCA events recently, we need to step back and consider the differential diagnosis for both INOCA and MINOCA. So INOCA can be due to coronary microvascular dysfunction or coronary vasospasm. And as we mentioned earlier, MINOCA has a wider differential diagnosis, which also includes coronary vasospasm. So given his long-standing chest pain, which happens mainly at rest, myocarditis was low in differential. Instead, coronary vasospasm was high in our differential. And we are thinking very likely his 2 MINOCA events happened due to severe vasospasm with possible superimposed coronary plaque rupture because he had non-obstructive coronary arteries in his angiograms. Also, it is possible that he might have a history of long-standing coronary microvascular dysfunction because there was sluggish TIMI2 flow in the LAD. So overall, as a next step, after he was discharged from his second MINOCA event, he followed up with Christ Hospital Coronary Microvascular Disease Clinic, and he was referred to invasive coronary functional testing to assess for coronary microvascular dysfunction and coronary vasospasm. Meanwhile, he was prescribed dual calcium channel blockers with amlodipine and diltiazem. Also, he was started on scheduled nitroglycerin patch and as-needed sublingual nitroglycerin.
So you mentioned invasive coronary functional testing. So can you explain to us what this procedure involves and what the patient can expect during and after the test?
Absolutely. So all patients referred for invasive coronary functional testing are instructed to hold all cardiac medications and caffeine for 48 hours prior to their procedure. Our patient underwent this procedure approximately a month or so after his second MINOCA event. So to begin, a routine left heart cath is performed first before any sort of adenosine or acetylcholine is administered. Once again, our patient was confirmed to have non-obstructive CAD consistent with his previous angiograms. Then, using a Doppler-tipped guide wire, adenosine is administered to induce steady-state hyperemia in the LAD, allowing for a measurement of the coronary flow reserve, also known as CFR. And the CFR is the ratio of blood flow during hyperemia compared to the resting blood flow. A CFR of less than 2.5 suggests endothelial-independent coronary microvascular dysfunction. And in our patient's case, his CFR in the LAD was 2.5, which falls within the normal range. Next, we administer a mid-dose of 54 micrograms of acetylcholine to assess endothelial-dependent coronary microvascular dysfunction, and a high dose of 108 micrograms of acetylcholine to assess epicardial spasm. However, in this case, we chose not to administer any acetylcholine after observing greater than 90% baseline vasoconstriction in the mid to distal LAD, which was associated with chest pain and ST elevation. The patient had an excellent response to intracoronary nitroglycerin, which successfully resolved the spasm, chest pain, and EKG changes.
Yeah, that's really incredible to think about, like how quickly the complete occlusion of the LAD can be resolved within seconds with just intracoronary nitroglycerin. And it makes sense that, you guys tested for microvascular dysfunction first with adenosine to make sure that that wasn't a cause of it as well, because there can be two types of dysfunction happening. In your guys' practice, for all patients with a suspected MINOCA or MINOCA diagnosis, you perform this testing of both the endothelial independent and endothelial dependent functional testing. Now, based on patient's history, do you guys pick only one testing or the other, or do you find yourself doing both types of testing for all patients?
We usually do both. We administer adenosine to assess endothelial independent coronary microvascular dysfunction. Then we administer mid-dose acetylcholine to assess endothelial dependent coronary microvascular dysfunction. Then we administer high-dose acetylcholine to assess coronary vasospasm.
Okay, gotcha. And in this case, it sounds like there was already baseline spasm. And it's really fascinating how it sounds like there was a pretty significant narrowing that resolved with administration of intracoronary nitroglycerin, correct?
Yes, it's correct. This highlights a couple of things. First, how effective nitroglycerin treating vasospasm, but it also highlights another important aspect in our practice. So, administering nitroglycerin prior to routine coronary angiography might be a key step in identifying underlying coronary artery spasm. Without this step, we take a risk of mistaking spasm as coronary artery disease. So it's a simple and effective strategy that can significantly influence diagnosis and treatment. That being said, I would like to shift our attention to his cardiac MRI findings after his MINOCA event. Now, we have a definite diagnosis, which is coronary artery vasospasm. So, Yulith, do you think the findings on the cardiac MRI might suggest some kind of cardiac remodeling which happened due to his recurrent spasm symptoms?
That's a great question, Mehmet. And I just want to say this just kind of to have a background for all of us. A cardiac MRI that is done within a week of myocardial infarction with non-obstructive coronary artery disease or MINOCA can secure up to 90% of accuracy in the diagnosis. But even if you do it within 3 months, still you have about 70 to 80%. So in our patient, the severe and recurrent episode of coronary vasospasm most likely led to ischemia that extended beyond the endocardial region, resulting in transient myocardial remodeling. This vasospasm-induced acute ischemia likely led to myocardial cell edema and inflammation, bringing about the changes noted in T1 and extracellular volume fracture, or ECV, and T2. These findings are very similar to what we see also in myocarditis, and probably that was what led to the confusion. In addition, the mid-wall leg gadolinium enhancement, or LGE, on his MRI may have represented myocardial scarring or fibrosis brought on by repeated ischemia and inflammation from these severe spasms. Something to keep in mind is that over time, these structural changes can gradually impact myocardial function, and even if you don't see a clear wall motion abnormalities or a reduced ejection fraction, is something just to keep in mind.
So that's really great. Thanks for putting together what we're finding in our invasive testing with what the MRI was showing. Now, this is so interesting because I think we actually have a diagnosis, right? And this patient has been going on for so long without a diagnosis, and now we actually have a diagnosis and a specific way to treat it. I think patients sometimes have a lot of peace of mind sometimes after they actually have a name for what they have, and we can have targeted treatment. Now, that being said, Namrita, what is the best approach to treatment for this patient?
Eunice, that's a great point you make. It's actually very interesting. I get to consent every single one of these patients that undergo these procedures, and speaking with them firsthand, many of them have been dismissed for years for saying non-cardiac chest pain or have anxiety and depression and everything that's not related to the heart. But we are the first people to give them that diagnosis. So it's very fulfilling to not only deliver them that diagnosis, but they get to walk away with a diagnosis and some treatment. And so to get started with the treatment, the whole purpose of the invasive coronary functional testing is to be able to not only provide a clear diagnosis and offer therapy, but obviously to improve their quality of life. So since his MINOCA events are driven by malignant vasospasm, our main goal is to reduce the intensity and frequency of his at-rest chest pain to prevent these future events. For epicardial spasm, the first-line treatment typically includes calcium channel blockers like amlodipine, diltiazem, and nifedipine, which help relax the smooth muscle of the coronary arteries. Long-acting nitrates such as isosorbide minonitrate can also be effective in relieving vasospasm via epicardial vasodilation and reducing oxygen demand. It is also recommended to avoid beta blockers in these patients with sole spasm. In the more severe cases, such as our own patient, where calcium channel blockers and nitrates have been maximized, dual calcium channel blocker therapy can be also considered. Additionally, sublingual nitroglycerin PRN remains essential for resolving acute chest pain episodes. For our patient, we continued aggressive risk factor management, and additionally, his diltiazem was increased from 120 milligrams twice daily to 240 milligrams twice daily. His nitropactor was also increased from 0.2 milligrams to 0.4, and then eventually 0.8 milligrams, which he wears for a majority of the day.
I got to say, it's so crazy how these patients, they often, when they don't have a specific diagnosis like this, they often get put on a beta blocker, right? Like maybe have some mild atherosclerotic disease. People think beta blocker is good for them, but in fact, in spasm, it's recommended that it's avoided. So it's actually really important, as you said, that a specific diagnosis was made. And secondly, it's always interesting for me to think about how much nitro it actually takes for these patients to have relief. I recently had a patient who still had chest pain in the office, has a known history of vasospastic disease, and they still exhibited coronary vasospasm on invasive testing. even while on a nitroglycerin drip. It was like a pretty moderate dose too. So we had to really increase their calcium channel blockers and their nitroglycerins pretty high. It's tricky business for sure. So I'm glad to hear that the patient has the appropriate treatment for his diagnosis. Now, I'd like to change gears and have you guys talk a bit more about the epidemiology of MINOCA.
And absolutely, I can help with that. But Eunice, I just want to go back to what you just mentioned. These patients are not just hard to diagnose, or it's a long road for them to get to the diagnosis, but then the treatment is not easy. And I know we're going to get to that a bit later, but it's just amazing how much care these patients require and how much, complicated and intricate it is to treat them well. So going back to, myocardial infarction with non-obstructive coronary artery disease, MINOCA, I would like to say it's not a single diagnosis, but rather a syndrome with a number of underlying mechanisms. And it's interesting just to look at what is a typical prototype of a patient with MINOCA. Usually are younger, usually female. In our case, we have a male, but most likely are female. And they have fewer traditional cardiovascular risk factors. Like a lot of them don't have like hyperlipidemia, let's say. But most of them present as a non-ST elevation MI. And in general, these patients are thought to have like better outcomes. But a recent study published by Dr. Quesada showed that actually patients that have MINOCA, but due to ST elevation MI, that they can have up to 2-fold higher risk of 5-year mortality when you compare them with MI due to obstructive coronary artery disease. So this is a very complicated topic because we are talking about, not just impact the patient, they're not the traditional patient, but on top of that, they can have also bad outcomes if we don't intervene them on time or treat them well.
You're so right. It really is quite shocking how these patients are somehow worse off, than those with traditional disease. This really highlights the importance of recognizing and treating these conditions, as we've been talking about. Could you walk us through the evaluation and assessment process for patients suspected of having MINOCA?
Sure thing. So the first step in evaluating a MINOCA patient or case is analyzing the clinical presentation to rule out obvious systemic causes of a type 2 MI, such sepsis, pulmonary embolism, cardiac contusion, or other known cardiac conditions that could explain the elevated cardiac troponin levels. After you have evaluated a patient and you realize, okay, there is no other explanation, the next step is carefully reviewing the coronary angiography for coronary artery lesions. You already know that they have non-obstructive disease, so you want to look for small coronary branches that may have blockage or narrowing more than 50%, usually in the distal portion, that it could be due to embolism, or even you will look for a spontaneous coronary artery dissection or a SCAD.
Very true, Yulith. Also, I would like to add that the most ideal further invasive step in assessing these patients should include intravascular imaging, such as IVUS or OCT, to identify if there is any plaque rupture. And if the diagnosis is still not clear, and if there is still concern for coronary vasospasm, an invasive coronary functional testing with acetylcholine should be considered to find the underlying pathology. However, it is available to remains limited and typically not performed in the setting of MI, although studies show it can be performed safely within 48 hours of MI.
Thank you guys so much for walking us through some pearls of MINOCA. Would you give us some highlights regarding general treatment?
Yes, of course. So the treatment of MINOCA, as we have been talking all along, needs to be tailored to its underlying cause. And to be honest, at the moment, there are no clear consensus in the guidelines, not even the American or European societies of cardiology. An example of this is like the European Society recommends the regular use of aspirin, statin, and calcium channel blockers for cases involving vasospasm. In contrast, the American Heart Association suggests using statins and antiplatelets only for MINOCA cases that are due to plaque disruption and advises against their use in like type 2 MI. On the other hand, there are studies coming out that show potential long-term benefits like from cardiac rehabilitation, medications like ACE and ARBs in the long term for these patients. So there is a lot to be said and look into when we talk about treatment for MINOCA patients.
Yeah, that's pretty challenging that the literature is not very congruent. I can see this field is pretty early in its investigations and in finding consensus. So, Mehmet, how is the patient currently doing?
After his coronary vasospasm diagnosis, he was counseled extensively on medication compliance and recognizing his spasm symptoms. He was also enrolled in cardiac rehabilitation program, which has been shown to improve outcomes in this patient population. Overall, our patient experienced less chest pain episodes, and the pain intensity has also decreased significantly. His quality of life improved, and he had no ED visit related to chest pain since the diagnosis. This really highlights how much patients can benefit from a definitive diagnosis, and also it highlights how important to educate patients on managing their chest pain flares up.
Thank you guys so much for walking us through this really educational case. I'm really glad the patient has a diagnosis and he has some targeted treatments. Do these patients usually follow with the same provider pretty frequently for medication adjustments?
So all of our patients that are referred to the CMVD program or the Women's Heart Center do follow up with our providers, nurse practitioners, nurses. And during our appointments, we educate patients that if they ever have chest pain to reach out to our nurses. And if it's outside hours or if they really have to go to the ED, to come to the Christ Hospital in our locations, because our emergency department knows to not make medical adjustments, as they know that too many cooks in the kitchen and we don't want to confuse the patient. We have a pretty collaborative environment with our emergency department and our cath lab. So actually the other interventionalists, if they do ever come across our patients, will go ahead and refer back to our clinic and let us manage these patients to the best of our ability. And then once we have made all of our patients stable and they're on a good medical treatment, we actually do discharge our patients and they're off to go see whoever they would like.
That's great. It sounds like you guys have a great system for following up with these patients, and I imagine it can lead to a decrease like repeat CATs and procedures for these patients. And as you said, kind of a central team that can take care of them. Do you guys usually repeat MRI for those that keep having repeated MINOCA events in the setting of a known coronary vasospasm diagnosis?
That's actually a great question, and it depends what we are looking for. If we're concerned the patient have any mimickers of MINOCA, so we are not sure that it's just a MINOCA event, then you will do it. You want to rule out Takotsubo or myocarditis. So sometimes we do it, and sometimes patients may have an episode 5 years or 10 years ago, and then they have another episode, and we are not sure what's going on. We will probably do a cardiac MRI on those patients again.
Gotcha. That makes a lot of sense. Is there a scenario where you would take the patient back and repeat their coronary microvascular testing in an invasive fashion like before, or do they usually just get, one time and they have a diagnosis and we go from there?
I think these patients evolve, just not in the case of MINOCA, but just talking in general about non-obstructive coronary disease. And let's say we have patients that have worsening symptoms, persistent symptoms, or they have major changes, with other risk factors that may contribute. I have seen patients like they have had testing probably 5-7 years ago. Symptoms are worsening. We think that patients are not doing better. And one of the things that you can do is a non-invasive testing first. Let's say you can do a cardiac MRI or a SPECT, and you find that their, microvascular disease is worsened. You don't have to do it, but in some cases it's worth doing it because, if you have a patient that you weren't 100% sure if they have epicardial vasospasm or just small vessel disease, you can go back and do it on those. It's very, I would say, uncharted waters for everyone, and especially for the interventionalist team. Here at where I am right now, I have seen quite a bit of patients have it, maybe because of the volume, and patients that have been in the program for 20 years. So they probably have like 15 years ago, and I have seen a couple of them having to have a repeated one.
Awesome. Well, thank you guys so much for walking us through this case and giving us these wonderful learning points. I think this is something that happens a lot, and we don't necessarily, go through the extra steps of diagnosis all the time, but it's very important, especially for those that have such a high impact on their quality of life. I'm sure it can mean a lot. So thank you, Namrita. Thank you, Yulith and Mehmet, for joining us and walking us through this case.
Thank you for having us.
Yeah,
That's
thank
quite
you.
fun.
That was fun and hard.
Thank you for your patience.
This was just an absolutely amazing conversation. Really walked through a patient with a confusing chest pain syndrome and really highlighted that it's not always about obstructive coronary arteries. You went through the extra mile to like kind of elucidate what was going on with this patient. And ultimately the patient sounds like they had a tremendous symptomatic benefit from a diagnosis and then appropriate titrations of treatment. And also it sounds like the program that you have at Christ really highlights the success of several experts focusing on a particular disease entity and building out a program that really benefits the entire system. Because as we know, chest pain syndromes are, extremely common. And to have a program like yours, I think is just tremendously valuable to your patients. So thank you so much for such a terrific conversation.
Thank you.
Thank you.
Expert commentary is provided by Dr. Odayme Quesada. She is the medical director of the Women's Heart Center at the Christ Hospital and is one of the leading physicians and cardiologists treating women and men with non-obstructive coronary artery disease in the region.
Thank you for having me on CardioNerds to talk about this very interesting case. My name is Dr. Odayme Quesada, and I am the medical director of the Women's Heart Center at the Christ Hospital and assistant professor at the University of Cincinnati. I think this case highlights very important points about the importance of the patient history and taking into account our testing, even subspecialized tests, and fitting it into a story that makes sense. So our patient had very classic rest, severe chest pain, sudden onset with a lot of associated symptoms, which stopped him in his tracks, had numerous stress tests, numerous cardiac testing, and multiple ER visits, and had been told that this was non-cardiac. And then he had 2 episodes of MINOCA, of myocardial infarction with non-obstructive disease, pretty much back to back, and came to us because we have a MINOCA program set up where patients with an MI with open arteries are essentially referred to our CMVD program, our coronary microvascular dysfunction program, urgently. It includes trending troponin. So it's an order set that we created where troponins are trended to peak. A cardiac MRI is ordered as stat, ideally gets done in hospital like it did for this patient, and then an expedited referral to our CMVD program. So that's how he got to me. And when I heard his story, he had a cardiac MRI done as an inpatient, and the diagnosis that he was coming in was with acute myocarditis. However, this just did not make sense. This gentleman had years of recurrent rest chest pains and now had 2 MINOCA events that to me sounded pretty much like coronary vasospasm. Usually our approach to someone presenting with MINOCA where we are suspicious for coronary vasospasm is to send them to a coronary functional angiography with acetylcholine for spasm testing. So that's exactly what we did in this case. And it was not surprising that we confirmed that he had vasospasm. And in fact, I was quite concerned with his history, his 2 MINOCA events, that he had malignant vasospasm. So even while we waited for the invasive functional testing to get scheduled, my suspicion was so high that I actually started him on empiric treatment with calcium channel blockers, maxed out, which is first line, and then nitrates, nitro patch, which was also maxed out. And then a calcium channel blocker was added after the invasive functional testing that confirmed that he had severe vasospasm. That was the approach that we used with him. I do want to make another really important point, which is the fact that he had ANOCA, a diagnosis of angina with non-obstructive disease, for years, even before the MINOCA event. And it's very obvious that this was spasm all along. And so one of the things that I did when I was recruited in 2020 to the Christ Hospital was to build the coronary microvascular dysfunction program, which lives under the umbrella of the Women's Heart Center. And this has been our most successful program. We have a registry that also started from the beginning of seeing patients, that it includes over 3,000 patients. About 1,800 of them are ANOCA patients, including MINOCA. And then we have over 600 patients have had invasive functional angiography. So because we have such a high volume of ANOCA patients, we don't just send everyone to invasive functional testing. So the way that we approach this is really depending on the symptoms that the patients have and the severity. So for example, if a patient is presenting with predominant exertional symptoms and they're mild to moderate, we will start empiric treatment with statins, ACE, ARBs, and antianginals such as beta blockers, first line, second line, calcium channel blocker, third line, Renexa. And if that improves dramatically, great. These patients end up getting usually a stress MRI or stress PET to evaluate coronary microvascular dysfunction. For patients with more severe symptoms, we start empiric treatment, but sometimes we may refer those to invasive functional testing, or if it's pure exertional symptoms, we may just do the non-invasive testing to confirm for coronary microvascular dysfunction. In patients with predominant rest chest pains, if they're mild to moderate, we may just do empiric treatment with calcium channel blockers and nitrates. And if it resolves, then we essentially don't proceed. If they don't improve with empiric therapy, or if they're presenting with moderate to severe symptoms of rest chest pain that is concerning for vasospasm, those are patients that we send to coronary functional angiography with acetylcholine testing. And then the last group, which is where this patient falls into, are patients with MINOCA. If we're suspicious for vasospasm, we definitely will send these patients to coronary functional angiography. Patients with a history of obstructive coronary artery disease, and patients with mixed symptom, meaning if someone has both exertional symptoms and rest symptoms, we usually send patients very early on in their workup to the invasive functional angiography, because that's how we're able to evaluate for all of the endotypes. So we're able to test for non-endothelial dependent coronary microvascular dysfunction, which is also what we test when we use stress MRI and stress PET. But then additionally, with acetylcholine at mid dose, we're testing for endothelial coronary microvascular dysfunction. And then at high dose acetylcholine, we are testing for microvascular spasm and epicardial coronary vasospasm, as we did in this patient. And so that is our approach. And in fact, we are very fortunate to be invited to do 2 manuscripts in CCI that were just published. The first one highlights how we built such a successful coronary microvascular dysfunction program in the context of a women's heart center. If you build it, they will come. And the second one outlines how we approach, in a program with such a high volume, how do we approach ANOCA patients? So who do we perform non-invasive testing on, and who do we perform invasive functional angiography? So I would refer you to those 2 manuscripts to learn a bit more of how we created our program. But again, I think this case is quite fascinating because it teaches us to question the result of our testing. So going back to this case, once I confirmed my suspicion that this patient had coronary vasospasm, it didn't make sense that his cardiac MRI was consistent with acute myocarditis. So I actually consulted with Dr. Mazur, our advanced imager, and asked him to re-review the MRI images in the context of now a diagnosed severe coronary vasospasm, and explained that this patient had had very severe episodes occurring regularly, 2 MINOCA events back to back. And in this context, our expert actually said, well, actually, this is very consistent with that history. A patient with severe spasm is likely becoming ischemic in different territories. And in fact, this cardiac MRI definitely fits the picture of severe coronary vasospasm, likely spasming different arteries in different events, which is why it looked like a global ischemia on the cardiac MRI. So it turned out that his cardiac MRI findings were not so discrepant after all. They actually fit this picture of a patient with malignant vasospasm, recurrent ischemia, and that's why we saw evidence of ischemia throughout the myocardium and not just limited to one coronary artery. Really quickly, a plug for MINOCA, myocardial infarction with nonobstructive coronary artery disease. We published a study that essentially showed, and this was in JSky, that if you look at patients presenting with a STEMI, we compare patients with obstructive disease, MINOCA, and MINOCA mimickers, and we looked at 5-year mortality. And what we found, which was pretty surprising, is that patients with MINOCA had a higher risk of 5-year mortality than patients with obstructive disease. And so again, it is critical when patients are presenting with an MI, even a STEMI, and they have open arteries, that we investigate the cause of their MINOCA event. Ideally, these patients should have intravascular imaging, either with IVUS or OCT at the time of image to see if there's evidence of plaque rupture or a missed SCAD or an embolic event. Then we have the cardiac MRI, which ideally should be done inpatient during the hospitalization for MINOCA. That helps us in cases where we are not really sure what happened. Also, it rules out acute myocarditis. And so this is Takotsubo cardiomyopathy. So it's a great test to do right away. And then last but not least, make sure that these patients are not being dismissed and that they're put on appropriate therapy. So studies have shown that in patients with MINOCA, if they get put on a statin or an ACE-ARB, even if we don't know the etiology of the MINOCA, there's actually an improvement in outcomes rather than not treating them at all just because we don't know the etiology of their MINOCA event. So hopefully you got some great pearls from this fascinating case. I'm excited to report that ever since we gave him a diagnosis, we put him on the correct antianginals, which included double calcium channel blockade and high-dose nitrates. He has not had any more ER visits, and this is someone that was going to the ER frequently. And so this is a great case of the difference that we can make when we listen to the history, when we give someone the appropriate diagnosis. Again, thank you so much, CardioNerds, for your time.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Christiana Dangas. I'm an intern in the CardioNerds Academy and a senior at Boston University. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.
Hey everyone, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, then keep on listening, because Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you. So just imagine leaving your office at the same time as your last patient. Now, wouldn't that be delightful? Freed AI is HIPAA compliant, secure, and takes less than 30 seconds to learn. Team, artificial intelligence cannot replace you, but it can do the administrative work that will allow you to spend more quality time with your patients and enhance your personal work-life harmony. So get back to doing what you love, helping your patients, and let Freed AI do the rest. Check out www.getfreed.ai to learn more.